and the continuation of infectious medicine. Today I will discuss cerebral abscess. So what is cerebral abscess? Cerebral abscess is defined as focal suppurative infection of brain parenchyma surrounded by vascularized capsule. So cerebral abscess is defined as focal suppurative infection of brain parenchyma that is surrounded by thick vascularized capsule. Now cerebral abscess, it causes the brain to swell and cause destruction of brain tissues. Mainly cerebral abscess, it is presented with fever, headache and focal neurological deficit. The fever pattern is on and off in cerebral abscess, and headache, it may be morning headache or nocturnal headache but associated with vomiting. While in focal neurological deficits, it is mainly presented with third cranial nerve palsy and sixth cranial nerve palsy. So if the abscess is get ruptured, so the patient is manifested with a worsening headache with the sign of meningism. So the most common cause of cerebral abscess, that is streptococcus. So streptococcus, it is the most common cause, up to 60 to 70% cases, while toxoplasmosis can cause cerebral abscess, but mainly in HIV patient with the CD4 count less than 50 to 100. Also, bacteroides can cause cerebral abscess, and that is 20 to 40%. That's how the abscess is spread to the brain. Now abscess is spread to brain by two ways, that is directly direct spread or by hematogenous route. Now if there is otitis media, or if there is mastitis, if there is otitis media or if there is mastitis, so it is mainly involve the temporal lobe, and ultimately it form the temporal abscess, or that is cerebellum abscess, right? So if there is otitis media or mastitis, it leads to temporal lobe abscess. If there is ethmoidal sinusitis, if there is ethmoidal sinusitis, so it causes frontal lobe involvement and cause the frontal lobe abscess. Similarly, if there is dental infection, so dental infection also involve the frontal lobe and cause frontal lobe abscess. So overall, mainly it depends upon the drainage of venous. So usually infection involving the face and ear, the venous drainage is towards the brain. So venous drainage, it carries the bacteria up to the brain and cause the cerebral abscess. If I talk about hematogenous route, and hematogenous route, blood carries bacteria and brain. Now in hematogenous route, there are multiple abscesses formed in the middle cerebral artery. So what is the most initial diagnostic test? The most initial diagnostic test in cerebral abscess, that is imaging. So what is the most initial diagnostic test for cerebral abscess? That is imaging. In imaging, the MRI, it is more effective than CT scan. Now when you do MRI, in MRI you will see that centrally there will be hypodense area, with the peripherally, that will be ring effacement. So, and if you see in MRI, there will be classically hypodense necrotic area in the center with peripheral ring effacement. While if I talk about the most confirmatory test, the most confirmatory test in cerebral abscess, that is biopsy. And biopsy will tell you whether it is a abscess or whether it is a tumor. It is surgical drainage of abscess via burr holes with biopsy. So the question is, why burr holes? So why we are not giving the empirical antibiotic therapy? So the reason is, in cerebral abscess it is surrounded by thick capsule. So when you give the antibiotic empirical therapy, it can't penetrate through the thick capsule. So but we can give the antibiotic empirical therapy before the surgery. So what are the empirical antibiotic therapy? So the options available for cerebral abscess, that is third generation cephalosporin with metronidazole, with or without vancomycin. Right? So what are the antibiotic empirical therapy in case of cerebral abscess? That is third generation cephalosporin, metronidazole, with or without vancomycin. So how we can give the antibiotic empirical therapy for the pyogenic abscess? If there is pyogenic abscess, if there is pyogenic abscess, so when we give the empirical antibiotic therapy for the pyogenic abscess, we can give this antibiotic if the brain abscess is less than 2.5 centimeter, if history of symptoms is less than 2 weeks, if there is no signs of ICP, intracranial pressure. So when we give empirical antibiotic therapy in case of pyogenic abscess for 6 to 8 weeks intravenously, if the size of brain abscess is less than 2.5 centimeter, if the history of symptoms is less than 2 weeks, and if there is no signs of intracranial pressure. Now if there is intracranial pressure, so what is the management for the intracranial pressure? So in that condition you have to give the DEXA, but it is controversial, but you can give DEXA for short period of time. So that's all about cerebral abscess.